So what are the indications for an antibiotic-coated nail? Well, one-stage conversion from X-fix to infix. We know that if we take an external fixator off and put a nail in, that there's some incidence of infection after that, certainly a risk. Frame holidays don't seem to actually fix that problem. If there's a history of infection in the area, it probably makes sense to use some sort of antibiotic-coated nail. History of X-fix for lengthening. So these X-fixes particularly have been on a long time, probably have had pin infections, pin loosening, and that sort of thing, similar to one-stage conversion. But this is interesting, a history of X-fix. So patient may have had an external fixator 5 years ago, and then you put a nail in, lengthening nail. This is where it's been seen, and it gets infected. So that's a real problem. Low incidence, but it's a real problem. Non-union for exchange nailing. So if I have a non-union and I'm going to do an exchange nailing, how do I know it's not infected? What can I do to mitigate infection if there's positive intra-op cultures? It's too late. I won't know for 4 days there's positive intra-op cultures. So I have the opportunity to coat my nail. And then open fractures, I don't know. I'll let Joe field that one. I'm trying to focus here on fracture-related infection, but fracture-related infection and PJI worlds do cross over quite a bit. So here's an example of where I used an antibiotic-coated nail. A 68-year-old male has liver disease, he has MRSA, failed total knee, and he actually pussed out his spacer, so he was not a candidate for another total knee. So fortunately here, we don't have a massive bone loss, right? It hasn't had 3 revisions. So I can get pretty good bone contact here. I use an external fixator because, that's the soundest of principles. Remove all dead material, put an external fixator on. There's no hardware at the site. And then compress it. And of course, most of these patients are not A hosts, and they don't heal that well. So then what? Well, then we're faced with, the guy's been in the frame for 3 months, 4 months, 5 months, and it's not a complete union. How do I deal with this? Well, the best way to deal with it is to put in a nail, right? Convert to a nail. So you have partial fusion at the fusion site. This is really common with knee fusions. And you don't want to keep the frame on any longer because you can't take the phone calls anymore. Patient's miserable. And, we're trying to be nice and help our patients and not torture them with the treatment too badly. So putting the nail in is a great way of doing this. We take the fixator off, put a nail in. If I put a nail in one stage after having that frame on, there's a good chance it's going to get infected. So I coat it with antibiotic cement. And this has been a go-to treatment for us. We use the Janet Conway technique of taking the silicone tubing, pumping cement in, pushing the nail through it, letting it set, cut the tubing off, fashioning a bullet tip point as seen with the yellow arrow, and then over-reaming a lot. This is a 10 nail, so I'm over-reaming to like 13 to get this thing in here, 13.5, excuse me, because the inner diameter of the tube is 12.5, 13.5, 14. What if you get the anaconda nail where it looks like a snake that swallowed and it's bulging out in one place, and then now you're reaming to a 17. It's awkward. The tibia doesn't love the big nail either, so it's hard to get it more than halfway down the tibia. So there's some issues with this technique because the bulk of the nail increases tremendously with the cement. Look how uneven the cement mantle is. Where the yellow arrow is, follow it up. There's no cement anteriorly. There's tons of cement posteriorly. Visually, it's covered in cement, but this gives you a sense of some of the shortcomings of this technique. I can't use bigger than a 10 nail. If I use an 11.5 nail, I'm going to get such a thin mantle of cement, it's going to fall off when I put this thing in. So that was some of the issues we have with that technique. If you go to the literature, we actually recently published a paper looking at our success with this technique and was competitive with good success rates using the PMMA antibiotic loaded coated IM nail. So why change? Well, I've alluded to some of the issues we have with it. One answer is that there's no need to remove the calcium sulfate. So do you need to remove the PMMA? Well, I don't know. If you did need to remove the nail, then sometimes the PMMA delaminates. You have to ream it all out. It's a bit of a hassle. If the stuff just dissolves, then there's a non-issue, right? Clinically, they seem to be equivalent in multiple studies. Some studies show that the elution properties of calcium sulfate is actually superior to PMMA. So some of the advantages of the absorbable ceramic is we don't need to use heat-stable antibiotics now. So it opens up the door for many other antibiotics. The flip side is that some antibiotics just don't mix well with calcium sulfate and prevent setting. So we have to be careful with certain antibiotics and how much we use. You can use a full-size IM nail. So from a workflow standpoint, you don't have to go to the back table and make a nail. You can pick whatever nail size you want that's appropriate for the diameter of the canal. And therefore, if you want to use a 10 nail, I don't have to ream to 13.5. I can ream to 11.5, right? So it's a little easier from a workflow. You can get a larger diameter nail. You can get a more appropriately matched nail. You know, does the cement give structural support? That's a debate that I'm not convinced it does. That a 12.5 nail coated in cement that's actually a 10 nail with a coating of cement that makes it 12.5 is structurally the same as a 12.5 nail? I don't think so. Paste goes everywhere. So part of what's nice about the calcium sulfate is that when you pump it in the canal and push the nail through, it's a mess. It's a complete mess. It pushes through all the old screw holes, pinholes, goes all over the soft tissues, and coats everything in antibiotics. So I think that's awesome. So we get penetration of antibiotics into the bone. None seems to be going into the lung, so that's good. That was one of my early worries. So here's an example of a ceramic. Patient has a non-union, treated in a frame, horrible host. This guy's like a C host, honestly. He's a B minus. And ends up, you know, end stage renal, diabetes, nice guy. Anyway, this fractures. So now he's had a previous frame. He has a history of infected non-union, and he can't take another frame. He's going to kill me if I try and put a frame on him. So, you know, what's an option? One option is using a nail, but I'm going to put a nail down in this area. I'm definitely worried about infection. So I want to fill his canal with this calcium sulfate with daptomycin, because of course he's allergic to vancomycin. Is that kind of case. And I push the nail down through this area. You can see the stimulan filling the canal. It makes a big mess, comes shooting out the non-union site. This is one of the cases where I use a compression nail. So this is a lengthening nail, pre-distracted, and then crushed. So we compress the heck out of this thing. The stimulan moves out of the way because it's brittle and it doesn't block the mechanics of the nail. That paper should come out pretty soon in JOT of using calcium sulfate antibiotic paste with compression and lengthening nails, no ill effects, and good infection control. So this is a compression situation, and this goes on to heal well, no signs of any infection at any point. So that's the idea. That's where I would use that technique. So again, this is a paper that we just had accepted to JOT, and we paid the open paid the open access fee. I don't know where the article is. The technique, can look at that quickly. I use Vanco and Tobra and 3 packs of Stimulan. That's my go-to for a long bone. For a knee fusion, it's more like 5 packs. So for 3 Stimulans, I use 3 Vancos and 1.2 at Tobra. You have to underdo the Tobra, otherwise the stuff doesn't set very well. I mix all the powders together, put the liquids in, add a couple extra drops of saline until it stiff peaks. This is like baking as usual. You get stiff peaks, put that into your syringe with a chest tube, custom cut the chest tube so it fits correctly, pump that in the canal retrogrades. Just take it all the way in and then pull it out as you're pumping it in, and then shove your nail in. Here's another example of using this technique. So here's a patient who, 36-year-old, has a Gustillo Anderson 3A, open fracture tibia. I did not treat this guy at this point, but clearly a waste of resources. He's gone through a couple different things. Then he ends up with a nail. It's very small. He ends up getting a non-union. Okay, so he's got a small nail in there. He's had 2 external fixators on. He's got a non-union, and my treatment for him is a percutaneous approach. Remove the nail, ream, but also percutaneously drill the osteotomy site and put in a compression nail. And again, I'm using the paste. So STIMULAN, Vanco, Tobra, filled this up. Of course, he has positive intra-op cultures for staph, 6 out of 6. So again, here's a guy who had negative ESR and CRP, no clinical signs of infection, but had a history of an X-fix, has a non-union, and has a nail with a non-union. So again, we have to suspect infection. Do you treat this with antibiotics or not? I guess that's a good debate. Since this was positive intra-op cultures, there's nothing I would have done differently. I agree with Joe that I didn't open this up. I didn't take this down. I just drilled it, reamed it, put a new nail in, and put my paste in so that I can feel good that my nail was covered in antibiotics and there's antibiotics in the canal. I did treat him with 6 weeks of IV antibiotics followed by PO suppression until the union, and that's our protocol here. One other application of this is pretty neat. Here's a patient who has an infected non-union. He's had multiple exchange nailings with antibiotic-coated nail, antibiotic-coated PMMA nails, multiple times. This area is just dead, right? So he keeps getting infected. We know what that means. This area is dead. Here's a CAT scan. How dead is that bone? I think this is a great educational CAT scan because you just see the normal cortex get not normal on the CAT scan. So that stuff's dead. It has to come out. And my plan for him actually is to use a frame. Here's the dead bone. It's always fun showing that. You can see the demarcation very clearly. So I'm using a frame for him. I'm going to take his nail out, do a resection, and do a classic 3-ring bone transport. But I have all this dead space in the canal. So another thing I've been doing is just pumping this thicker mixture, same stuff, into the canal. So you can see it's completely filling the canal, and I just kind of ignore it and go along with my bone transport. But I do feel like it does blast the canal with antibiotics for at least 6 weeks. When you mix it thick, it sticks around longer. And then go on to just do a classic bone transport. You know, was it necessary? I don't know. I think that it's easy to do, and it does deliver local antibiotics, and I do like that. I don't use a spacer then, and I'm getting good dead space control. I also use this for ankle fusions, like Charcot patient. Here's a Charcot corrected gradually with a frame, and of course, same like the knee fusion, they don't heal very well, and you get partial spotty healing. Well, let's follow that up with a conversion to a nail in one setting, pump the stimulant in the canal, shove the nail in there. Again, it goes all over the place, out the pinholes, coats everything in antibiotics. So what's my conclusion? We are now studying our PMMA coated nail population with our calcium sulfate paste population. So far, preliminary results show no inferiority of the calcium sulfate, and that's all we want to see. And personally, I've stopped using the PMMA coated nails, and I only use the calcium sulfate antibiotic loaded paste now.